All right, greetings everyone, and welcome to the December 11th, 2011 EKG case of the week. Today's actually December 12th, and I was working through the weekend once again. I seem to be working quite a few weekends. I'm not really sure who I pissed off, but anyway, I'm a day late, but so what? I've got a great case to talk to you about, and this case is not the actual case that we saw last week, but last week in conference we were talking about EKG findings associated with a certain condition, and it prompted me to think that it would be a great time to go through this case that you're going to hear about and show you a whole bunch of other EKGs to hammer home a particular finding. So what the heck am I talking about? Let's move forward. So we're going to start out with the case of a 72-year-old man who actually was on the surgical service when everything transpired. He was 3 days status post colon surgery for colon cancer. He's also got a history of cardiac disease, but had been doing pretty well. And now he's doing well post-op, and then 3 days after surgery, he developed some chest pressure and shortness of breath. Now, if that's the only information I give you, 3 days post-op, and he's got chest pressure and shortness of breath, you're thinking probably pulmonary embolism, right? Number one. Number two, you might be thinking PE, and number three, you might be thinking about pulmonary embolus, and then maybe four, you're thinking about acute coronary syndrome and a few other things. But the surgery contacted cardiology to come see this patient, and he had a 12-lead EKG. Let me show you his admission EKG first of all. And his admission EKG looks completely normal. There's no tricks or surprises here. But now he's got chest pain and some shortness of breath 3 days post-op. And here's his new 12-lead EKG. And he has T-wave inversions, V1, V2, V3. So very appropriately, cardiology and anyone else taking care of the patient thought he must have anteroseptal ischemia. And that's what 99% of the people in the world would probably look at and think. And a couple weeks ago, if we talk about the differential for T-wave inversions in V1, V2, V3, anteroseptal ischemia should jump out at you and make you worried. But we also talked several weeks ago about a benign pattern seen in young women called persistent juvenile T-wave pattern, and I'm not going to go back through that whole diagnostic set of criteria. This is obviously not a young man, so we can just knock that off the table. And there's one other thing to think about when you see T-wave inversions in V1, V2, V3, and that's what we're going to talk about. And this turned out to be. Anyway, they thought this was just anteroseptal ischemia, not inappropriately. The patient was treated with nitrates and morphine, pain got better, and somehow morphine has a tendency to do that, to get rid of pain. His EKG remained unchanged. He ruled out for an MI. They did I think a persantine thallium or some type of nuclear medicine stress test while he was in the hospital, and it turned out negative. So at that point, since he had been ruled out for acute coronary syndrome, everyone washed their hands of the patient. Now, going back to the very beginning, I said that based on chest pain and shortness of breath post-op, everybody would be thinking that he's got a PE. But in this particular case, because the patient had an abnormal 12-lead EKG, everybody jumped right to the diagnosis of rule out MI, rule out acute coronary syndrome. And once they did that, they forgot to take the workup any further. Well, the patient ended up being discharged, and that's when we got to know the patient, because the next day he decompensated, came in extremis, extremely short of breath, hypoxic, and at that point, now with the hypoxia, he goes for a lung CT, and he's found to have a saddle embolus and 2 other PEs, and he had persistence of that T-wave abnormality. There was no evidence of acute coronary syndrome. He ended up, fortunately, doing okay, and that's what we're going to talk about, the fact that large PEs have this tremendous tendency to cause T-wave inversions, very commonly in leads V1, V2, V3. We'll talk about some other patterns as well. Now, if you remember what the differential for chest pain is, well, I don't want to talk about the differential for chest pain. There's probably 100 things there. But the differential for rapidly fatal causes of chest pain in the emergency department, you think acute coronary syndrome, PE dissection, pericarditis / tamponade. You should also remember esophageal rupture, which is not that common, but you got to think about it, because if you miss it, the patient's pretty much dead with mediastinitis, and they're going to die within the next day or so. And then, of course, tension pneumothorax, which usually becomes fairly obvious based on the clinical presentation and the lung finding, not lungs findings, but lung finding, right? The issue here really, however, is is that when people have EKG changes in the presence of chest pain, there's this tendency for all of us to immediately rule out the bottom 5 conditions that I've listed there and just focus on acute coronary syndrome and forget about everything else. And once you've ruled out acute coronary syndrome, you forget to go back and think about all the rest of the things. But it's really important to remember that ACS is not the only thing that produces EKG changes that can look just like ischemia. We're going to talk about PE, which definitely can mimic cardiac ischemia. We know that an aortic dissection can do it as well. In fact, a common cause of inappropriate anticoagulation or even thrombolysis of patients with dissection is because these dissection patients oftentimes present with ST changes or T-wave abnormalities, and people think that the patient's got acute coronary syndrome. We know pericarditis and tamponade can mimic ACS. Esophageal rupture can cause some unusual EKG abnormalities, fairly nonspecific, but it can produce EKG changes. And any type of acute pulmonary disease can actually produce T-wave abnormalities. We're going to talk especially about PE and T-wave abnormalities, but there are studies indicating that hyperventilation can flip your T-waves, pneumothorax, tension pneumothorax, even pneumonia can produce some T-wave abnormalities, maybe even some ST segment changes. But what I want to focus your attention on during the course of this presentation is pulmonary embolism. That's the thing that you've got to be thinking about when you see T-wave changes. Now, here's a list of the classic EKG findings that we've probably all learned about. There is the classic S1, Q3, T3. That's a big S wave in lead 1, a Q wave, and a T wave inversion in lead 3. More importantly, this rightward axis, when you see rightward axis, one of the things in emergency medicine to always think about when you see rightward axis is pulmonary hypertension. And in emergency medicine, if it's new, if it's acute pulmonary hypertension, that's a PE. So rightward axis in emergency medicine, you've got to think about pulmonary embolism. Another sign of pulmonary hypertension, or right heart strain, sometimes people call it right heart strain, is a new right bundle branch block or an incomplete right bundle. In other words, a big R wave in lead V1. Normally you should have a tiny R wave, if at all, in lead V1. PE can produce supraventricular and ventricular arrhythmias, tachydysrhythmias, not commonly Brady dysrhythmias, but tachydysrhythmia is very common. It can produce ST elevation, ST depression, not that commonly, but it can. And what I want to really focus your attention on is T-wave inversions. It turns out that there's literature indicating that perhaps the most common abnormality in case series of large PEs is actually not sinus tachycardia, the way we've all been taught, but actually T-wave inversions. And it's a good time to remind people that sinus tachycardia, in the biggest studies to date, the Europed and PIOPED studies, sinus tachycardia is only present in 30 to 50% of cases. So many of us were taught the myth that everybody with the PE is tachycardic, or nearly everyone, and it is a myth. Most patients with PE are not tachycardic, but very commonly large PEs will produce T-wave inversions, especially in the anteroseptal leads, and of even more specificity is a combination of T-wave inversions in the anteroseptal plus the inferior leads. I'm going to say that over and over and over as we go through this talk. All right, so what produces the EKG ischemic findings in PE? There's a handful of different theories that you see up here, and I'm not going to go through this. Nobody really knows for sure, but there are a handful of theories and not a lot of research focused on why patients have ischemic findings in PE, but there are theories, and it definitely happens. T-wave inversions. So again, I'm going to mention that again. T-wave inversions are very common in PE, especially in those anteroseptal leads. That's relatively common. 30 to 50% of patients with large PEs will have T-wave inversions in the anteroseptal leads. That's just as common as sinus tachycardia. All right? And again, these are the bad PEs, not the tiny ones that we probably all walk around with, not the tiny one that I'm probably developing while I'm talking to you at this. Ouch! Oh, I just had another one. Not that one, but the ones that cause patients to be in extremis, or at least really short of breath and looking somewhat sick. Now, we'll take it one step further. If people have T-wave inversions in the anteroseptal plus the inferior lead simultaneously, it turns out that that's actually very highly predictive of PE. There's a handful of articles that have been published on this particular topic. The most recent one, Kasugi, in American Journal of Cardiology, indicated that T-wave inversions combined in the anteroseptal plus the inferior leads was 99% predictive for PE. Incredible. Now, we've done the study ourselves at University of Maryland, and it's supposed to be published in Journal of Emergency Medicine at some point within the next handful of months. And in our series, what we found that was that it was about 75% predictive for PE. That's pretty darn good. So in other words, in our practice, in my practice, if somebody has T-wave inversions in the anteroseptal plus the inferior leads simultaneously, that is a PE until proven otherwise. If you're in Vegas and you're going to put your money down on something amongst those 6 things that cause chest pain, put a lot of money down on pulmonary embolism, and you're going to win a lot of money. 75% predictive, and in Kasugi's study, 99% predictive. Is this something new? No, it's actually not. Marriott, Chow, Chung, Galen Wagner, some of the really, really heavy hitters in the world of electrocardiography, these brilliant cardiologists have been talking about this for decades, that this combination finding of flip T waves anteroseptal plus inferior leads is very, very predictive of pulmonary hypertension, and if those are new findings, acute pulmonary hypertension, in other words, that equals PE in emergency medicine. So let's look at some more cases. Here's another case. Now, this patient already has an S1, Q3, T3, but you know what? If you look at this patient's baseline 12 lead, the patient's got an S1, Q3, T3 already. So the physicians looked at this S1, Q3, T3 and said, you know what, it's baseline. We're not going to pay much attention to that. And that just goes to highlight how poorly sensitive and poorly specific the so-called classic S1, Q3, T3 is. It's neither sensitive nor specific. But what was new in this patient wasn't S1, Q3, T3. And by the way, you'll notice there's also a little incomplete right bundle branch block pattern here, and that's a sign of right heart strain. But for some reason, the patient kind of had, well, that's kind of new, I guess. The patient already had a little bit of an R wave there. Not that terribly remarkable. So let me go back. What's new on this patient's 12-lead EKG is some evidence of this right heart strain with relatively tall R wave in V1. In other words, the R wave is as big as the S wave. And the main thing I want to focus your attention on is these new T-wave inversions in the inferior and the anteroseptal leads. All right, so here's the baseline 12 lead. Here's the baseline 12 lead once again. And this patient ended up having a large pulmonary embolism. Here's another one. Here's an 80-some-year-old woman that came in with some chest pain. She had a history of COPD, so she got admitted for acute coronary syndrome and possible COPD exacerbation as well. The reason that they were thinking acute coronary syndrome is because she's got flip T waves, inferior and anteroseptal, so everybody called this inferior and anterior cardiac ischemia. Here's her baseline EKG, so this is a new finding. New flip T waves, everybody focused on acute coronary syndrome. She got admitted to the hospital, she got ruled out for acute coronary syndrome, and the next day plans were made for her to be discharged, and she had a cardiac arrest waiting for the family to show up to pick her up and take her home. And the family was really upset about this, and they ended up demanding an autopsy, and she ended up on autopsy being found to have a very large pulmonary embolism, no evidence of acute coronary syndrome. So new flip T waves, inferior, there you go, inferior and anteroseptal, predicted her big PE, but people only focused on acute coronary syndrome because they hadn't heard this lecture before. All right, next case, case number 4. Huge flip T waves, inferior and anteroseptal. This is a big PE. This patient got admitted to the chest pain center, got cardiac enzymes negative, went for a stress test, negative, went home. Everyone felt comfortable. This person has been ruled out for acute coronary syndrome. Patient went home, had a cardiac arrest. At autopsy, found to have a massive PE. And you know what? Nobody considered PE because everyone said, there's flip T waves. Rule out MI. Rule out acute coronary syndrome. You know what? When you rule out acute coronary syndrome, your job's not done. You still have to think about the other 5 causes of chest pain that we know can produce ischemic findings on the 12-lead EKG. Case number 5. Here again is a patient that's got flip T waves inferior and in the anteroseptal leads, and I think I've got a baseline 12 lead for you. And yep, here we go. And so these are new findings as well. So this patient's got new flip T waves inferior and anteroseptal leads, and this patient ended up having a big PE. Hopefully you're getting bored of this by now. I really, really want you to get so bored of flip T waves, the next time you look at a 12 lead and see flip T waves in the anteroseptal and inferior leads together, you just take a big yawn and say, it's a PE, go on to the next patient, right? So let's keep marching on, but I really want to drum this into your head. Here's an interesting one. We talked about how PE can cause ventricular dysrhythmias. Here's a patient that has intermittent runs, and this is only one 12-lead EKG, but during the course of his time in the ED, he kept having these intermittent episodes of non-sustained ventricular tachycardia, 4, 5, 6 beats of ventricular tachycardia, and this was pretty much everyone's response to that. They said, oh my gosh, this patient's got acute coronary syndrome, and that's all people were thinking about, because what else can produce runs of ventricular tachycardia? It's got to be acute coronary syndrome, right? So the patient got put on some lidocaine or amiodarone, and sure enough, that suppressed the PVCs. The patient ended up getting ruled out for acute coronary syndrome, and then they got a CAT scan, and sure enough, there was a massive PE. But you know what? You could have predicted it right from the very beginning, because even though your eyes might be going right to those runs of VTAC, you know what Homer's actually looking at? Homer's not looking at those runs of VTAC. Homer is looking at the flip T waves. Homer's not as dumb as you think. He's looking at the flip T waves here. And if you notice, there's flip T waves in V1, V2, V3, and he's got flip T waves in a couple of the inferior leads as well. He's got flip T waves inferior and anteroseptal, and just like Marriott and Homer have always said, that is a PE until proven otherwise. So this guy ended up with a big PE. He got anticoagulated. He got taken off the lidocaine or amiodarone, and with anticoagulation, he did not develop any more runs of VTAC and ended up doing okay. Now I'll finish up with this case, last case, number 7. This is kind of an interesting case, and this was a handful of years ago, and this really prompted me to go looking into the literature and discover all of this stuff. A 59-year-old guy presented to a community hospital that has a cath lab with 9 hours of chest pain, shortness of breath, diaphoresis. It's got a couple cardiac risk factors, and this guy does have ST elevation in V1, V2, V3. So this is not a flip T wave case. This is ST elevation. This is a septal STEMI for all intents and purposes. Here's his baseline. So he's got a new set of ST segment elevations in the septal leads. This is an anteroseptal STEMI, no doubt. So what ends up happening? Well, he goes right up to the cath lab with aspirin, heparin, nitro drip, goes to the cath lab. He's got no evidence of coronary disease. He's got no obstructive lesions. His cath is negative. So they stop the heparin, stop the nitro, and they give him a little morphine. And like usual, pain resolves with morphine. And he ends up being admitted to telemetry just to finish up the rule out. And there was no further workup of the chest pain or no further mention of the EKG abnormality. In other words, they saw what looked like acute coronary syndrome, they ruled it out, and then they simply stopped the workup. They didn't say, you know what, we've ruled out one cause of chest pain, now we've got 5 more things to think about. They just stopped. And unfortunately for this patient, he had no further workup. He ended up having a PEA arrest the following day, and autopsy showed a massive pulmonary embolism. Nobody considered that as a possible cause of acute ischemic changes on his 12-lead EKG. All right. So, bottom line here, just to finish up, PE can cause EKG changes that simulate acute coronary syndrome. So, always consider PE. Don't rule out PE just because somebody has some EKG changes. In fact, you should think even more strongly about PE if those EKG changes involve T waves. Even more strongly if the T wave inversions are occurring in the anteroseptal plus the inferior leads simultaneously. Again, that is a PE until proven otherwise. And finally, also remember the simple concept that when somebody's got chest pain and you're thinking acute coronary syndrome, that's fine. But once you've ruled that out, your job is not done. The job of the people upstairs is not yet done. Remember, when we see patients with chest pain, our job is to rule out all the deadly causes of chest pain, not just one. And if you're admitting patients and working them up in the chest pain center, please remember that as well. And remind your folks upstairs about doing the full workup, and make sure the people upstairs know about this T-wave abnormality, because this is not commonly taught. It's well published in the EKG literature, but it's not well taught in the general literature. So please keep that in mind. And if you do, simple concepts will save lives. That's it for this week, and I look forward to talking to you next week. Thanks a lot.